As you all know, with the diffusion of lung cancer screening and imaging technique, in the future we will have a large part of lung cancer detected in very early stage of disease. And these are data of our COSMOS study population, a large cohort of screen cancer that were 80% in stage 1 and 2, and average size was 1.5 centimeters. So it's clear that standard open lobectomy is an over-treatment for these patients, and that in the future, but even in the present, minimal invasive surgery should be approached this kind of tumors with a tailored volume of extension and also a tailored lymph node dissection. So if this diagnostic revolution is still already ongoing in US, we expect an implementation in the future, even in Europe, in the rest of the world, because we recently had the release of the data of the Nelson trial, a randomized trial compared screening for heavy smoker versus the standard of care, which is nothing in Europe. And we have the confirmation that the screening cancer are in most cases stage 1 disease, so an important stage shift with lung cancer screening. And also we have important data related on the mortality, lung cancer specific mortality, with around 30–40% reduction at 10 years. So this stopped the debate in Europe as to start or not to start screening, and will be implemented surely. In addition, we have data from our previous study that show how lung cancer has a very large variability in terms of aggressiveness, against the hypothesis that lung cancer can be or very indolent or very aggressive. We have a continuum variability of volume doubling time, which is an important prognostic factor. It is very easy to determine it during lung cancer screening, as you have nodules that are follow-up for very long time. So VDT is also a prognostic factor. As you can see, we have data that show how VDT is correlated to mortality. For this reason, we can add this parameter to other, like size, volume, and density, and SUV. VDT also will be important to define the best treatment, not only to decide if one patient should be operated or not, but also what kind of surgery offered to this patient, if subsegmental resection or wedge resection, or even wait and see or sub-treatment. So important is a tailored treatment. And this concept is very important also in the extent of lymph node dissection. As you can see here, we had a large series of stage 1 disease screen cancer detected and treated with anatomical resection and radical lymph node dissection. The conclusion of our paper were that you can find very important prognostic and predictive parameters, like size less than 10 millimeters and SUV. If one of the two parameters are present, you have very, very rare cases of involvement of lymph nodes, so you can spare lymph node dissection in these particular cases. So regarding the extension of resection, we have a number of retrospective studies that show how subglobal resection are adequate type of resection with similar local control and survival compared to lobectomies. And this is ongoing, the validation in terms of randomized clinical trials. So in the meantime that this trial give the results, we have these clinical practice guidelines today, where indication to segmentectomy are related to multifocal lung cancer, elderly patients or high-risk compromised candidates, selected recurrent tumors, tumors less than 2 centimeters where a parenchymal margin of the size similar to the tumor can be obtained. But also the type of approach is very important. We know that VATS segmentectomy is not an easy procedure, it's challenging, and we know that a robotic system can really introduce important technical advantages. So with this paper, we described the robotic technique in 2012 in a multi-center study, and we concluded that improving dexterity and vision, robotic can make minimal invasive segmentectomy easier to adopt and diffuse and perform. So with the infusion of this procedure, we have the risk, the segmentectomy, the risk that many surgeons go back to the open lobectomy, open segmentectomy, because the challenging VATS. So then in 2014, we also described the possibility to augment the vision of segmental plane with introduction of injection of ICG. And here just show you an example of a patient with 2 lesions, one in the middle lobe and one in the segment 6 on the right side. We had diagnosis in one of the 2 nodules, which was an adenocarcinoma, so we decided to offer middle lobectomy associated with segmentectomy to avoid the bilobectomy. So this is the early phase of the middle lobectomy vein isolation. You can see here we introduce the staplers to the posterior port. These are standard staplers, endoscopic stapler, because of a cost issue in our hospital. Then we have the standard resection of the bronchus of the middle lobe, and the introduction was through the utility incision. We usually don't perform this kind of procedures with CO2 insufflation. It's very similar to the VATS approach with utility incision at the beginning in the 4th or 5th intercostal space. And this is the resection of the pulmonary artery of the middle lobe. After this, of course, the transection of the parenchyma of the middle lobe, and is performed using the standard endoscopic staplers, and the resection is completed with another stapler. Then we have isolation of the pulmonary artery branch of the S6 segment, and transection using the standard staplers. We have then isolation of the pulmonary vein, unusual visualization from the anterior aspect. Here, then the transection will be done posteriorly. And then the isolation of the bronchus for the segment, always through the fissure, so anterior vision, and transection of the bronchus. So after the vein transection, we will see the use of ICG. As already said before, we inject endovenously, and we have around 3 to 5 milligrams of ICG. And in this particular case, the nodule was very low, as you could see in the CT scan, very low at the margin with the segment 10. So it was very useful to have the clear demarcation of the anatomical feature of the segment to obtain a radicality in this case of the resection. So just a note, we know that indocyanine Fox green has been introduced by Fox in 1957, and Kodak also, for cardiac output studies at Mayo Clinic. And since then it's been used also for imaging and localization of nodules. We have different endoscopic imaging system with near-infrared light. And for robotic, we know we have the intuitive Firefly, but also other tools are available for VATS surgery. Another note is that contraindications are very rare, just the iodide allergy patients. We must be aware that ICG has up to 5% of sodium iodide, but severe side effects are very, very rare. So it's a safe procedure. This is another case where we did a left upper lobe Lingula-sparing resection for a patient with 2 lesions, which were metastases from adenocarcinoma of the colon. One was in the lingula, so we did a small wedge resection of the lingula, and the other was in the center of the upper lobe, so we did a lingula-sparing lobectomy in the same patient. After the isolation of the structures and resection of the vein and the artery of the segment, we isolate here the bronchus, sparing the lingular segment bronchus. And the introduction of the stapler is from the back, in the 4th arm robotic port, after removal of the port. So this is a disadvantage to have standard stapler and not the robotic stapler, so we lose time. This is 2. However, in Europe, the costs are very, very high for the staplers, endoscopic staplers. Very few centers can afford it without reducing the margins. After the closure of the broncho, we always inflate to check the position of the stapler and the airflow in the other segments. Then we staple it. We inject the ICG, and we could see here very well the margin of the segment to make a more precise resection. And you can see that the limit of the segment was exactly where we had the previous wedge resection, so it was easy to complete the segmental dissection. And this is my last movie, a robotical superior segment of the left lower lobe. It was a very old woman, 79 years old, with a 3 centimeters nodule, adenocarcinoma. This is the isolation of the pulmonary artery in the fissure. The anatomy was very favorable. And here you can see the dissection of the lymph nodes in the fissure and transection and preparation of the plane and completion of the fissure posteriorly, which was complete. Lymph nodes were removed. The artery is isolated and transected. Can go to the next step. This is the isolation of the pulmonary vein for the segment, for the superior segment, with the lung which is retracted anteriorly, and after lymph node dissection of the L9 lymph nodes. Here we complete the posterior aspect of the mediastinum of the hilum with the isolation and dissection of the lymph nodes from the artery and the fissure. And we isolated the bronchus from the posterior aspect, differently compared to the previous segmentectomy. And the stapler is introduced through the anterior port, which is the utility incision port. We inflate and deflate. And then ICG injection can help in definition of the plane, intersegmental plane. You can see, then we put this kind of tools from the utility incision to define the stapling line. And we completed the resection. So as said before, the infrared systems are available also for video thoracoscopic procedures, and I found this paper particularly interesting for to describe the description of all the phases they use to make a basilar segmentectomy, which are the most difficult segments. So the use of 3D reconstruction is very useful and available in many centers. We will be equipped with this in the very near future. The interoperative localization using bronchoscopic navigation is also another very important step. At the end, the use of ICG, you can isolate the artery, and after isolation of the artery, you inject the ICG with near-infrared scope, and you can see the margin of the segment, but not only the margin of the segment, also the pulmonary vein can be identified easier because it's not fluorescent, and this is something that I personally didn't know, so it's important to take into account that you can check the vein after the isolation of the artery and injection of ICG. For difficult segment, this can be really an advantage. So to conclude, segmentectomy will be a very frequent operation in the near future, in particular also in Europe with the diffusion of screening. The 2 randomized studies are ongoing to validate the oncological adequacy. That segmentectomy is challenging, even if we will see that very expert surgeons are able to do that easily. Robotic system may make minimally invasive segmentectomy easier to adopt. And ICG injection is very easy and safe method to improve identification of intersegmental plane and vascular structures. Thank you for your attention.